So, nurses, this is you. Clearly you're sitting down regularly, and those who are supporting nurses. So in the PHN, we know that you're running, we know that you have conflicting priorities, and you know it's really hard to stop and assess the current situation to think about planning for future changes, etc. And if you did think about doing that, what tools would you use? How would you garner support from your team, from the extended team? How would you show proof of outcomes for your patients and in dollars? Because quite often when we speak to practice owners, we need to show a dollar outcome as well. How do you get PHN support? So the couple of you that identified as not having engagement with your PHN, how does that happen? And as I said, how do you engage the team, but not just the movers and shakers, but the whole team, because we all know when you work in general practice, you need the support from admin right through to the general practitioner. So I'm here to encourage you to work with your primary health network and to grow that relationship. So one of the tools that we have used, and many of you have used the PenCat data extraction tool, is, can you read that? We've developed a practice support plan, and this actually isn't the plan that we're about to move into, and we're up to our 3rd edition. So when we moved into primary health network land from Medicare Local, we realised that a lot of the support that we'd been providing in practice support was a reactive type of model. And we wanted to really move into a proactive, but also still giving some reactive support. And I'm happy to send through this if anyone. I see lots of photos, none of me. But I'm really happy to share these later if you would like, and I can give you some of my cards. So this is a really simple tool to use, and it's taking a quick snapshot, as I said, at the practice. We've got some data from about disease prevalence in the local government areas, so we can see, does your data reflect what the profile is showing? Is there an increase or decrease in your data, and is that maybe a coding issue? So we can examine that kind of thing. And we look at what kind of health promotion activities there might be and how we can support and link practices up with those sort of activities, which would encourage and increase engagement in their patient population. This model is initially developed with the practice manager. Sometimes the practice manager may invite one of the nurses or one of the GPs to the initial setup of this plan. This is page 2. So as I said, this is under development and we're going to start looking at a new tool, but with similar points in it. The portion of the PIPs and SIPs, and like I heard, and all of you primary health network people would have heard yesterday, that the PIPs will be turning to POPs. Instead of practice incentive payments, we're going to have practice outcomes payments. So looking at data and planning means that we can move to that POP model a bit more readily. So when you look at the payments that practices are receiving, is it what you thought? Are you doing the work? Did you think you were doing more work? Is there gaps? How's the recall system? Is there gaps in education and knowledge in how to better manage this? In our primary health network, when we then do this model, we would look at some of the areas where the practice would identify where there are gaps and look at structured support and education. For example, you know, we've done a lot of work, and you would have, some of you heard one of my colleagues, Casey, speak yesterday about the Diabetes Alliance, and that looked at some of the gaps in education and claiming and support and better outcomes for patients, which is where we're heading. So, the steps. The plan, as I said, is often developed with the practice manager, and then the nurse may provide some clinical comments and look at driving change towards change in implementation of nurse-led clinics or areas of focus. So most of you in this room would be really familiar with that. The plan may examine current practice versus maximising MBS, because we need to be honest, and general practice is a small business, sometimes a very large business, and if we don't make the income, we can't sustain and we can't look after our patients. What are the population requirements? So, you know, I'm living in Newcastle, and there's areas of Newcastle that have really high rates of asthma and COPD because of the industry that we live and work near. So are we meeting the requirements of that population? So we identify the need with the practice support plans, and for example, I worked with a practice in that area who identified high asthma rates, problematic issues in managing asthma cycles of care. We all know that it's a tricky one to manage. And so they called in the local hospital CNC and went through, did some in-house training and developed a plan on how to approach their asthmatic patients and how to support them for better outcomes. So obviously all of this approach is dependent on relationships and building trust and rapport. Once the plan has been developed with the practice manager, we attempt to get buy-in and support from the whole team. So not all practices have whole team meetings. Some may have some clinical team and a separate admin team, but we do encourage the whole team to be presented with the plan and look at and identify gaps together. So most of you know this snapshot. Is there any nurses in the room that use PenCat? Yep. Do you like it? Yeah? Okay. So the practice support plan is used in conjunction with data analysed from the PenCat data extraction tool. This is a nothing shot. This is just a filler to give you an example. There's no real information in the graph there specific to the whole discussion, but just a general overview how we would get a snapshot and use that as well. So these are part of the support tools for developing a strategy and looking at, you know, a business plan or a model for moving forward and understanding where to focus. It also provides lists to work off. So lots of practices my colleagues and I go to, the lists are generated and nurses or some of the administration staff are given list after list after list. Do some of you get handed a bundle of lists for recalls or follow-ups or diabetes cycle of care with people with only 1 or 2 items remaining, that kind of thing. The idea is that that's great to get lists to work off, but let's look at the whole picture. So the key areas, and many of you are really familiar with this, we cross-check population data with the LGA stats. We use the resource to move in a direction. We check the data to reflect billing and completed cycles. So this can all be done by garnering support from your PHN, and I think pretty much all of the PHNs provide PenCat data extraction tool or a data extraction tool. You know, and for example, with our Diabetes Alliance, are they a candidate? Do you have a large cohort that may be able to be moving into one of the other projects? And lots of you in your areas have other projects. We're going to hear from Liz shortly talking about COPD. So there's lots of other stuff going on that your patients in your practices can be linked into. Use the PHN to empower you and support you. When we're looking at something to work on, we want to start small. So I keep seeing the guys from Orange Sky Laundry. How unreal was that? I must be menopausal, I was crying, like most of the room. I am menopausal, sadly. Start small, you know, and I know Tracy, who's trained me for years in data extraction and printing lists, don't print out masses of lists. We've got to pick up little things at a time and work together, and if we're working as a team. Identify any needs in skill gaps in the team and look at quality improvement for the whole practice. You know, quality improvement can be leveraged off for accreditation and CPD, particularly with our GPs and their change in their triennium and the quality improvement stuff that they've got to do. The tools are not there to tell practices how to do things, they're just conversation starters and looking how to identify areas, presenting outcomes at practice meetings, but that in itself is just to encourage meetings. Do the nurses in the room have regular meetings? Most of you? Do some of you work in practices that you don't have meetings? Yep, you just go to work and do the do. Pardon? Yeah. Yep. So regardless of all of that pre-stuff, if all we get out of our visits and our support is encouraging teams to meet, we're thrilled. So it's starting small, and that might be the shift, that there's a monthly meeting or a little get-together. We want all staff to have a voice. So of course, you know, we're really pro-nurses and we're really pushing that, that voice, but we want all of the staff in the team to have a voice, and we value everyone's input and engagement. So there's just a couple of quotes from some nurses who have used the tool and used the plans to move forward to an area. And I'll just read one of them. Getting the owner to buy into time out to plan is the absolute key. So getting to time out to plan is really hard to sell, because that's time when you can be seeing patients. You often need to provide dollar outcomes to balance the time I require. Over time, I will prove this method is preferable to the knee-jerk ad hoc style of care we often provide currently. It doesn't mean, and the nurse that wrote this, Louise, it doesn't mean that the care that she's not giving in a knee-jerk ad hoc style is not good care. It's great care, but there's no planning and vision ahead. Nurse value using these tools in tandem with primary health network support. Questions to ponder. And then I said this won't hurt a bit. Change. Change can hurt a lot, even if it's a tiny shift in change. So the questions to ponder for you as practice support, people looking after the nurses, and for the nurses out there, are you looking forward? How can we assist you? What time is required? Can you use the admin support to assist? Is your education in line with the focus area? So if we were looking at the diabetes management, are you all doing diabetes education around the same time? Or has it been 3 years since you've done any updates? Health promotion and prevention resources, you're trying to tap into what's happening at that period of time. And do you know what help is available, proactive versus reactive? Change is hard and it can hurt. Lean on those that have been there, done that. So as some of my colleagues from other PHNs spoke yesterday, still shamelessly, don't reinvent the wheel, lean on each other. And this is the really awesome thing about being in conference altogether. Use tried and tested models, and understand it's really hard to step out and take time to analyse. Shift happens, and often nurses are the ones that are the key to change. We're the middleman between the patient and the Prac GPs, etc. Looking at building agent capacity, looking at the barriers and prioritise. So what are the barriers? Are they in-house barriers? Is it the way the practice is set up? Is it the way the patient gets greeted at the front desk? Is it the way a next appointment is made? Generate sponsorship. So sponsorship may be the practice manager, maybe the owner, maybe an influential patient who comes to the practice who's been coming for 20 years. So generate sponsorship with them. And looking at the hammer or transition approach. The hammer hurts a bit, but it's over and done really quick, and this is how we're going to change. The transition is slower and steadier, but sometimes people fall through the cracks. I was at a practice recently, and one of the GPs who'd been working at the practice for a number of years, they were moving to a brand new built practice, the same team moving to a brand new setting, and that doctor had to have the desk, the pens, the computer in the same place, and they took photos and they basically picked it up, moved it a suburb away and plonked it down, otherwise she wouldn't move practices. So obviously change for that GP would be very slow. You're all laughing because you all know people like that. Some of them might be you. Who says nursing is stressful? I'm 39. I'm actually 21 and feeling great. Nurses, you are awesome. This is what you do. You have unpredictable jobs. You genuinely care, not just about your patients, about your colleagues, about your bosses. You assist patients and their families, not just the patient that walks through the door. You care about who looks after them at home, what their kids are up to, etc. You're great communicators. You have intuition. You're critical thinkers, which particularly the lady from Health Director's gone, but I know doing telephone triage, critical thinking is high up there on the list. You have the ability to coordinate patient care, coordinate your time in practice, and you're detail-oriented. So with these skills, thank you, you can make those little changes and really lean on those who can support you to do them. These skills equip you to do big picture stuff. Imagine the capabilities of these skills with support and encouragement from those that are here to support you, which is your primary health networks and APNA. Thank you for your time and energy.